Hi guys. Well, I'm sorry I'm not with you on this Friday. We have scholarship summit going on again, but I wanted to share with you content that I think is valuable for us each to have a better appreciation of, because our own personal experiences and past narratives may not make us very well aware in some cases of some of the inequalities that are present and systemic in healthcare. So let's get started into this content. First, from John 13, verse 35, it says, "A new commandment I give you, love one another as I have loved you. So you must love one another. By this, everyone will know that you are my disciples, if you love one another." One of the things I'm asking you to do prior to this lecture is to just watch a TED Talk. While we're not together, one of the things I would have been asking you to do is to think about what you feel like our responsibility is in regard to this particular aspect. That I'm going to leave for your personal reflection, or maybe I will make it a weekly reflection question here soon. But let's move forward into the content for today. Before, I suppose, we move into the content, though, some of these ideas can be controversial, and some can actually make you uncomfortable or make you feel uneasy. I think it's very important that we remember that humans are all deserving of quality health care, in my opinion, and discrimination and prejudices shouldn't exist in any setting, but in the healthcare setting, um, along with other spaces. So what do we mean by inequity or inequality in healthcare? So as we look at some of the information around healthcare, the inequity we're referring to is either overt or covert discrimination that takes place within healthcare settings or healthcare context. It makes it so that some groups of individuals end up to having poor health outcomes and are really marginalized. Some of those marginalized groups include women, as well as individuals of color or racial minority, and our LGBTQ plus populations as well. One of the things I think is helpful to remember is that prejudices are your perceptions about other groups. Discrimination is the action you take based off of those prejudices. This is a short video that I hope will help bring to light some of the reasons that there can be a significant distrust between, in this particular case, African Americans and the medical system, but there are examples of this kind of marginalization and abuse of authority within healthcare for numerous populations.
Today in the Daily Dose, the Tuskegee syphilis experiment, a study in unethical medicine. From 1932 to 1972, the Tuskegee syphilis experiment was a study conducted by the U.S. Public Health Service designed to study and observe the natural progression of humans infected with untreated syphilis. Conducted entirely on poor, uneducated African American men in and around Tuskegee, Alabama, the study was run in collaboration with Tuskegee University, then known as the Tuskegee Institute, which enrolled 600 African American sharecroppers from Macon County, Alabama, including 399 men with latent syphilis and a control group of 201 men who were syphilis-free. As an incentive for participation in the study, the men were promised free medical care, but were deceived by the U.S. Public Health Service, who disguised placebos, ineffective methods, and bogus diagnostic procedures as effective treatment options. The men who had syphilis were never informed about their diagnosis, despite the risk of infecting others. and they were never informed that the disease could lead to blindness, deafness, mental illness, heart disease, bone deterioration, central nervous system failure, and death. Instead, the men were told they were being treated for bad blood, which was a Southern colloquialism used to describe anemia and fatigue. After the introduction of penicillin in 1947, now the standard treatment for syphilis, none of the study participants were given the antibiotic, while scientists further prevented study participants from accessing syphilis treatment programs available to other residents in Macon County. After the unethical study was exposed by Cub Associated Press reporter Gene Heller, the American public was outraged to learn about numerous syphilis-related deaths in the infected study group, along with 40 wives who contracted the disease and 19 children born with congenital syphilis. The egregious breach in ethical standards led to major changes in U.S. law and regulations concerning the protection of participants in clinical studies, as well as the establishment of the Office for Human Research Protection.
So today, America does remember the hundreds of men used in research without their knowledge and consent. We remember them and their family members, men who were poor and African American, without resources and with few alternatives. They believed they had found hope when they were offered free medical care by the United States Public Health Service. They were betrayed.
And there you have it, a bad 40 years for American medical ethics. Today on the Daily Dose, get your nerd on with the Daily Dose.
Okay, so while it's clear that we established legislation to try and combat those kinds of lack of ethical treatment of other individuals, you can absolutely understand, I think, why individuals from subcultures or from not the dominant culture might be skeptical when American medical systems are saying, no, we're doing everything we can for you, because that has been the message in the past as well, but has also not been the truth in the past. As we look at some of the information that research has to tell us about inequality and inequity within healthcare, we can start by looking, this is an article from 2011 around the perceived discrimination between, as well as what is the communication that's taking place between patient and provider. So first, the quote that I pulled out here is defined as the perception of a differential and negative treatment because of one's membership in a particular demographic group. So when they're looking at perceived discrimination, they're looking at the opinions of those individuals within a particular demographic group and whether they feel as if they're being discriminated against or not. That's being further compared against how providers actually communicate with patients, and comparing that against other demographic groups. People who perceive, or groups that perceive in discrimination, that's often leads to or is associated with a disengagement or removing themselves from the healthcare system. That if I'm being discriminated against, why do I want to participate in that? It also means significant delays in obtaining care. So if you're disengaging from the healthcare system, then you are certainly less likely to be getting care in a timely manner, as well as just not utilizing preventative services and not following the treatments and recommendations given by doctors or physicians or other medical staff of any kind. It leads to a higher rate of missed appointments, as you can imagine, if you feel like you're being discriminated against, if you feel like you are being talked down to, if you feel like you're not being heard. Why even attend appointments where you're only going to feel prejudice expressed? It also means, or leads to, is associated with a preference for alternative forms of medicine over the conventional systems. So let's look at some of these pieces here. We can look at racism first. So, or as we look at the columns that you see here, we see the African American versus white. And here's the questions that we're looking at. When getting healthcare, have you ever had any of the following things happen to you because of your race or your color? So they're also looking at your socioeconomic status. So, did you ever feel like a doctor or nurse wasn't listening to what you were saying? Well, you can see almost 60 people to 20. That's almost about 3 times increase that African Americans felt like they weren't being listened to, that they were being treated with less respect. Similar outcome. Received poor health services, maybe even an elevated outcome, significantly elevated outcome, actually. Treated with less courtesy, 5 times more likely if you're African American to feel like you were treated with less courtesy than white. And you can see that these things are also tied to socioeconomic status. So as we look at individuals that were in lower socioeconomic statuses, you see white individuals reporting that they felt like they were either not listened to or not respected, or that they received poor services. But that's even further exacerbated or even higher, again, compared to the whites in African American individuals. So people's understanding and perception of how they're being treated, and what that's dependent upon, like that's really changing who is receiving medical services, how effective those medical services are, whether the person wants to even be engaged or not. There's a lot that goes into there. So what were the author's recommendations on trying to overcome these inequities? Part of it was first making sure that physicians learn better listening strategies, that they understand differences between cultures, but that just in general, they learn to listen more effectively and more actively. They recommended that physicians should communicate in a way that shows they're considering the patient's concerns and their preferences in treatment. The physicians should be sharing the treatment, not only the diagnosis, but the treatment recommendations with clear articulation that I've heard what you as a patient are interested in and what your preferences are, and here's how I propose we move forward. That unconscious bias, that which would also be known as prejudice, that is another thing that the author said we really should be training doctors against and trying to eradicate. The increase of just understanding that the way a person feels about how they're being treated and their perceptions is going to impact their long-term health and their health care. Just understanding that was another recommendation, that everyone should be cognizant of that impact. And that your communication style is really, really important. Now, here's an article from 2015. And the title of it was "What Difference Does Difference Make?" And these authors wanted to answer a basic question: what impacts our health and our well-being? So we've already talked about here in our class some of these concepts like neighborhood and social networks. We've hit upon the idea that educational background and maybe some occupational and economic resources all fit into those. And we talked about that as the social determinants of health. These are some of those components of that social determinants of health that we know have a bigger and bigger impact on a person's health and well-being than were historically recognized. But here's a new one: the stress of racism, of poverty, discrimination, and marginalization. This is a new area. So the authors of this particular article referenced some previous research. And they said that previous research demonstrated these different things. that providers actually spend less time with non-white patients on average. So people of color who were perceiving themselves as not getting equal treatment, that's accurate. The providers ask white patients more open-ended questions, that they show more empathy with their white patients. So the way that we communicate, the healthcare system was communicating, and the amount of time they were spending, and the way that they were demonstrating respect indeed was different. In a study of white and Black HIV patients, doctors were more verbally dominant with Black patients, according to not just the research, but the summary of past research. Black patients are more likely to be treated by a less experienced physician. Patients who see a provider of the same race report the visit as more satisfying and participatory. So there's a comfort level and maybe a language and cultural mannerisms. There's a number of different ways that communication impacts how we feel when we're being seen by a provider. And the more comfort a patient has with their physician or other healthcare worker, the better that the health and well-being of that person is likely to be long term. In continuing with the summary of past research in this area, they identified that non-white patients are less likely than white patients to see a physician of their race, and that ERs and cancer treatment facility non-white patients are less likely to receive pain medication. So these are all indicators and findings from past research that really reinforce that being different really makes a difference when it comes to what you receive from a healthcare standpoint. So if there's so much research showing that this is a significant problem, why is it continuing? Well, there's a number of different things that they articulated. First was that patients approach an encounter with all of those previous healthcare experiences, not only their own, but the shared experience or the shared narrative from their family members and loved ones. So if you have not only been experiencing prejudices and discrimination in your own experience, but you've also heard from your mom and your sisters and your grandma and et cetera, that all of those things were happening to them too, then you go in with that anticipation. The patients approach each medical encounter with their previous work experience, which is also likely to mirror many of the exact same attitudes and behaviors, as well as what's happened in recreational type settings. From the other side, those that are providing, physicians approach the encounter with the perspectives on that they've gained with all of their education and their professional training. Also, all of the past experiences they've had with other patients in the past, as well as their own healthcare, all feed into the way that physicians are anticipating or expecting a meeting with a patient to go. It's also true, of course, that their physicians' race and their class and their social position all feed into their perspective on what is effective communication, what is the way that you demonstrate respect, what is the outcomes that are expected, etc. So how are we going to overcome all of these things? Because patients are approaching with all those past experiences and all of those experiences with discrimination and trauma. Physicians are coming with their own perceptions of what is going to be taking place or what is effective as far as a medical care appointment goes, which may be centered around efficiency rather than respect and long-term positive outcomes. So the authors of that article that we identified earlier made a couple of recommendations for solutions around this. The first, again, was there you see communication, improve your communication training for your healthcare providers. But beyond just improving communication, we need to make systemic wide changes to just allow providers more time to actually spend with individual patients. You may have experienced this feeling yourself that you get into a medical appointment, you feel like maybe you've waited in the waiting room for longer than you saw the actual doctor or nurse practitioner or whomever you were seeing. And you may have felt like you were rushed to not be able to share everything that you wanted to share, or that you didn't have time to discuss, that it was just a what's the problem? Here's the solution. The authors also say that more focus on emotional aspects associated with medical appointments are important. So we're being able to recognize and to be able to help people deal with anxiety or fear around a medical appointment are really important. And then again, just making providers aware that their actions are creating these disparities is a really important component. So I think some of the things that is also helpful to see, we talked about the biopsychosocial model, and I think you're seeing that echoed here within the recommendations from the authors of this particular article, that we need to be looking at the psychological aspect, not just the biological aspect of healthcare. And we already mentioned that the compressed scheduling of appointments is an elevated and continuing problem within healthcare. Okay, so we've looked at this across different cultures. What are some of the other different areas that we said groups were marginalized and were definitely experiencing healthcare differences? One of those communities is LGBTQ plus. Now, what is the cause, or where do these discrepancies or inequalities come from within this community or within serving this community? This is an article from 2018. So the authors of this article say that the basic root causes are our own social norms, our own cultural and social norms that prioritize cisgender and straight patients and deprioritize transgender or gay patients. They also say that stress associated with sexual orientation and gender identity and sexual characteristics elevates this challenge, that victimization as well as discrimination and stigma are all these fit really well within this biopsychosocial model, but also are really the root causes of why LGBTQ communities are experiencing significant differences amongst their health than when we look at peers, but with a different sexual orientation or sexual identity. So this again is more information from that same article out of 2018. But this population, LGBTQ plus people, are, they say, the authors say they're much more likely to experience stress, which then, of course, we're at least moderately aware or mildly aware that increased long-term stress leads to physical challenges as well as mental health challenges. And LGBTQ plus population is much more likely to experience those negative implications. In a big study of the LGBTQ plus community, this is paraphrased within that 2018 article, they reported that 55% of that population self-reported a history of being verbally harassed or attacked, that 45% of that population reported being sexually harassed, and that 41% reported general discrimination, whether it was just kind of bullying or hostility or rejection or whatever it may, whatever methodology or whatever actions might have been, they were just sort of discriminatory in it. but not falling into the category of verbal harassment or sexual harassment. Altogether, again, though, just like as we saw with previous results, this kind of discrimination and this devaluing of individuals and this communication, whether it be overtly or covertly, that you're not wanted or respected or as valuable as others, means that it's going to lead to individuals who are feeling that, who are experiencing that, to just want to avoid that situation. In a healthcare setting, that means that they are avoiding preventative actions, they're preventing or they're avoiding regular visits, which might identify issues before they get significantly worse. They're avoiding treatment. And this is even to the point of avoiding emergency care because of the pain of the bias and the discrimination that individuals are experiencing. So how does this show up from a physical health and a mental health standpoint? When we look at LGBTQ plus individuals compared to cisgender or straight individuals, gay or bisexual men have higher rates of musculoskeletal problems, GI problems, liver and kidney disease, and even some types of cancer. When we look at women, lesbian women have higher rates of polycystic ovarian syndrome or PCOS, which can impact fertility as well as just general health. When we look at the mental health side of things, we can find data and studies that show that compared to cis or straight individuals, that we see higher suicide attempts, we see higher suicidal ideation, that we see much higher rates of depression and anxiety, about 1.5 times higher in LGBTQ plus individuals than in the standard population. Along with that, alcohol related or other substance abuse related dependence is again about 1.5 times higher. So there is a lot. We also see isolation as a very, very common experience for individuals in the LGBTQ communities. So all of these are definitely things that I think you and I would not want anyone that we knew or cared about to be experiencing, regardless of what group they belong to or identify with. So these are definitely areas we want to be working to be at least aware of. And hopefully through that awareness, we help to be an active voice in decreasing. Now, we're still in that same 2018, or actually, no, this is a different 2018 article. This was titled Barriers and Solutions for Health Providers. And as you can tell from the title, they're going to be identifying barriers and solutions. So let's talk about some of the barriers that they identified first. First, that providers show a lot of discomfort or unease when meeting an LGBTQ patient. The second barrier is that there's not always a good understanding of the unique needs of the members of that committee, that an understanding of what's correct terminology and vocabulary is often lacking for the straight or cis population, that they're not really recognizing the gender identity or sexual orientation of the patients that they're facing. They're only looking at the biological sex characteristics and not the individual's sexual orientation or gender identity. So all of these things then lead to really poor trust and really poor communication between both the patient and the provider in healthcare settings. Now, what do they propose as solutions? The first is that healthcare facilities should just continue to grow this culture of respect and inclusion, and not just to LGBTQ, although that's what this particular article was focusing around. That education and training about correct terminology and common health concerns is definitely incredibly important, and that we should be in healthcare providing resources to all the LGBTQ individuals to just help to reduce as many possible barriers as we possibly can. I think all in all, the solutions are that we need to love each other better. and that we need to respect each other better, and we need to show each other respect better. So, having seen some of those kinds of statistics and some of that kind of information as we've looked across cultural and we've looked across sexual orientation as different classifications where we see discrimination present and rampant. Let me ask you this one as we look into another category of where discrimination takes place really, really commonly. Who's more likely to use an emergency room for medical aid, and who's more likely to use primary care or office visits for medical aid if we're thinking about men versus women? Who do you think is more likely to use one versus the other for that particular type? Well, let's look at what we can find from gender disparities within healthcare. Women are definitely much more likely to seek care in primary care settings, and men actually use emergency medical services at a much higher rate. So men sort of have a tendency to not seek regular medical advice and instead go into the emergency room. Women are less likely to use the emergency room, more likely to use ongoing primary care services. So while women actually have a much higher utilization of health services, their needs still aren't being met. And I think that's really, really important for us to get a sense of. Among patients who would benefit from some of the treatments, fewer women receive actual coronary angioplasty, coronary artery revascularization, renal transplants. There's a number of different spaces here that are different between men and women. Now, I didn't do the best job of leading into that, I don't think. One of the ways that we've seen this play out is that men and women are just different. Big shock to any of us. But when men are experiencing heart attack or experiencing chest pain, myocardial infarction, they typically experience it more or describe it more as a crushing chest pain. Women who are experiencing the exact same condition will describe it differently. There's a much higher rate of women describing it as just not feeling right and as if they're having a much harder time getting their breath in. And based off of the way that they're explaining and expressing and experiencing these events, there can be incredibly different results in the way that healthcare providers interpret the event that's going on, with the bias towards the way that men experience and describe a heart attack is what a heart attack is, and what women are experiencing must not be a heart attack. But the blood vessels surrounding the heart are definitely smaller in women, and the way that they develop disease is different than it is in men. So their experience, while still leading to a life-threatening condition, is going to be articulated and actually experienced differently. When we look at osteoarthritis, this is certainly more prevalent in women, but fewer women actually seek medical care for osteoarthritis, or they'll actually postpone seeking that care until the condition has progressed to significantly later stages. The TED Talk that you see there would also re-articulate and articulate probably better some of those differences in the heart attack warning signs between men and women, where men are seen as typical or described as typical, and then women experience this atypical, but still significant and scary. Other connections or other things that you should be aware of when it comes to gender disparities. When we look at most medical research, it historically was really done just on males. And the rationale for that was that females were just too irregular, that because of their hormone fluctuations, that they were too challenging to be able to do effective research on. In fact, 80% of all the drugs removed from the market are actually due to the side effects that are discovered when it's released, when that medication is released and consumed by women. So all of the drug research being done on men, then they say, okay, this is safe, release it. Both men and women are consuming it, and women respond differently. And because of those different responses, there's real danger, and we have to remove drugs because they just weren't tested on women. It's interesting that the number one killer for both men and women is heart disease, but women die within the first year of a heart attack much more frequently than men. And a lot of that comes back to the way that treatment takes place following a heart attack and the way that communication, the way that healthcare workers are understanding the description and whether they are considering that to be something that's severe enough that maybe it was a heart attack or not. Whereas men, if they come in with that typical description of heart attack, then all of these protocols are enacted, which might not be enacted for men. I think I've shared with you this particular experience, but one of the things that really brought this about to me, this gender disparity about to me, was my wife had a really significant herniation in her back. And she was just in agony for years. But as she would go in and see medical staff, they would often tell her, like, yeah, well, if you can handle it right now, then we don't want to pursue surgery. So as a very tough-minded individual, and she just kept postponing and saying, oh, I'm trying to live with it. I'm trying to deal with it. Eventually she ended up seeing a new provider or a new physician who, when he pulled up her CT scans, was like, whoa, you're like one of the worst cases I've ever seen. You've been like this for years. Well, how come you haven't pursued surgery? And she relayed, well, I've been told over and over again, like, if I am able to manage on my own, then let's not pursue surgery. Never being told, like, relative to other people, yours is far and away more significant than most other individuals that we do any kind of surgery or look at anything like that on. Well, that was a negative experience by itself, but where it became much more realistic for me, or much more tangible for me, it had gotten to the point where she wasn't really safe to drive herself because of the pain. And certainly as we're going to see the specialist, the surgeon who's going to be performing this, like, we both wanted to be as fully informed and fully aware as we could be about what was going to be happening and what to expect. So in the next appointment, which was with this well-renowned surgeon in the Portland area, he gets in and he's already, like, he's done all of his work. He's read through the file and he knows the information, and he's really well briefed on my wife's condition. My wife's sitting on the table thing there, and is clearly obviously is the one that's there, that we're there to talk to. Excuse me, I had a little burp. But as a surgeon comes in, he says hello to both of us. And then every question he asks for like the next 10 minutes is all directed straight to me, asking about, well, how does she experience pain? When does it hurt her here? And how does she do this? And how does she do? And everything is directed to me. And he didn't ask her any questions. And after felt like a really long time. It might have only been like 5 or 6 minutes, but it felt like a really, really long time with that. I was like, listen, she's right there. Just talk to her. She knows all of these answers with far better detail and experience than I do. I just couldn't understand why this male surgeon would constantly keep asking me instead of just turning to the expert in the room, who is my wife that's been living with this thing for a long time. Hopefully you never have any experiences like that, but you may, or other members of your family may. We also know of things like generational trauma. So the APA says, has some studies about how mass cultural or historical traumas can really impact future generations. So looking at major events like the Holocaust or Native Americans being displaced or slavery and its impact on African Americans. This has a long-term psychological and neurobiological impact. It's not just cultural. And certainly it impacts the social dynamics, but it further can lead into genetic implications. Initial studies APA conducted show increased rates of PTSD, increased rates of depression, increased rates of anxiety and drug use in the descendants of these generations. So even though it's not the individuals that lived through personally these tragic and horrific experiences, their sons and daughters and even grandsons and granddaughters and some spaces and places, it continues generations beyond that even, that we see this implication to their mental and their physical health. Now, some of that the APA suggests is based, or some of the causes of that are potentially like these fear-based survivalist type messages that are just passed on to their children, like you got to watch out for these people, or you can't trust those people, or you can't, whatever those types of, however we could conceptualize or paraphrase those without using specific names or titles. It also potentially can be attributed to the higher rates of stress-related genes. So as we learn more and more about the influence of environmental triggers on the expression of genes, which we know of as epigenetics now, that is a definite potential cause. And that even those cortisol rates, so as a woman is experiencing these great stressors and is biologically expressing more cortisol as a result of that stress, then the fetus is experiencing all of these elevated cortisol levels as well, and that has a long-term impact on the development of what will become a kid. So how are we going to help with improving some of these things? Clearly, I think we've heard over and over again that awareness and education and training around these issues is really, really important. That professional training should include cultural sensitivity and an awareness or an elevation of our own prejudices and our own unconscious bias. That providers should really work to develop improved communication skills, not just active communication skills, but also their listening skills and thinking about communication as being both covert and overt. And that we work on programs for improving access to care for all groups that are experiencing marginalization. I don't know if you can think of other important suggestions that would be really, really valuable. That would be a really good piece for us to be hearing and for you to be sharing. So as I present the exit ticket to you for today, that exit ticket is going to ask you just this question, what else? And this is what it's referring to. What is your own idea on some other way or ways, or what do you think is most important in trying to deal with this challenge of inequality within healthcare? So, a couple of questions maybe to ponder across this weekend. Should we focus on resolving these healthcare disparities by creating equality or creating equity? Do we need to accomplish some sense of equality before we create equity? Or do you think, what do you think? Those are the things that I think would be helpful for you to continue to ponder across this weekend. Please make sure you fill out the exit ticket so you get credit for participating in watching the video today. And thanks so much. I appreciate you being here. Have a good rest of the day.